necrosis because it leads into like a cottage cheese type of consistency of the tissue. Also gangrene. Gangrene is something that we do see in the prep room, and it can either be what we refer to as wet gangrene or it can be dry gangrene. Wet gangrene occurs on the venous side within the veins, because remember, veins take blood away, veins take blood back to the heart, while artery starts with A, it takes blood away from the heart. So we refer to wet gangrene and venous obstruction. We use those interchangeably because since veins have the job of getting the blood back to the heart, those extremities, particularly the feet, veins really have to fight the force of gravity in order to get that blood back up to the heart. If for any reason the vascular system is compromised, then that blood is not able to get out of that part. Thus, that limb begins to swell and distend. With gangrene, it has a horrible smell to it. The tissue begins to turn a bluish, purplish kind of color, and the extremity is typically cold. But that's because the blood cannot get out of that part. That is, on the venous side, wet gangrene. However, dry gangrene can occur as a result of the blood not being able to get to the part. In this case, you get just the opposite. Instead of there being too much blood pulled in the extremity, the blood can't get to the part. So the oxygen can't get to the part. So therefore, hypoxia occurs, the tissue begins to die. As a result, you end up with hardened, blackened digits, such as the toes, that eventually would either fall off, or in the case of wet gangrene, the potential for amputation is there, because all of the bacteria that is present in that area could potentially poison the rest of the organism or rest of the system. In addition to that, excuse me, someone just walked in the room. Okay, sorry about that. In addition to that, there is a microorganism that you need to know, and we will talk about it more when you get to micro if you're not already there. But it's in that paragraph, the second to the last paragraph, Clostridium perfringens, goes into greater detail in the book. But this is the microorganism that can cause us a tremendous amount of trouble. That is because it is the causative agent for tissue gas, and that's the postmortem condition of gangrene. Antemortem, we call it gangrene. Postmortem is referred to as tissue gas. And one of the ways that you can determine whether a case has tissue gas or not is by the process of crepitation. Crepitation is an area where there's an area beneath the skin. I'm sorry. This is your professor here. I am so very sorry. I did not anticipate. Can you please leave? Can you please leave? I need to sit. I am so sorry about that. I'm so very sorry. Can you leave, please? Get out. I'm sorry. I'm sorry. Let me try to get myself back together because I can't even remember what I was saying. Clostridium perfringens, also known as Clostridium welchi. Let me write it down. You've got perfringens in the text, so I'll just put welchi, W-E-L-C-I-I-C. Yeah, I think that's it. They're the same microorganisms, but that's the microorganism that can cause gas gangrene antemortem and can cause tissue gas postmortem. But I was talking about crepitation, because in crepitation, the way that you would know that a case actually has tissue gas is beneath the surface of the skin. If you touch the skin, it kind of crackles almost like tissue paper, and that's an indication that this particular microorganism is present. One of the things that you need to remember about this microorganism is that it anything that you use on the case that has tissue gas will need to be sterilized. It has the ability to create what are called endospores, and endospores are like a force field that the microorganism will put around itself when the conditions become unfavorable. Once the conditions change, then the microorganism comes out of that state and it can continue to live. The only way that we can kill this microorganism is via sterilants. So we would need to sterilize either our instruments in an autoclave, or we would need to use a chemical bath that has glutaraldehyde or some other sterilant inside of it in order to arrest further decomposition and cross-contamination. That's what I was trying to say before I was interrupted. Okay, so let's get back to the text. Back in the text, atrophy now. Let's move on to atrophy. Atrophy can be either physiological or can be pathological. If it is physiological, then it's something that will automatically happen. And the example that I give you in the PowerPoint presentation is the uterus. After pregnancy, the uterus will go back down to its size. That's normal. However, pathological atrophy can occur as a result of poor nutrition, if you don't use it, no nervous stimulation. An example of disuse. For the longest time, and I think I've told you before, I tore my Achilles tendon. So for about 3 months, I had to rely on my left leg to do all of the work. So as a result, when I was finally able to come out of the boot and the shoe and off the crutches and everything else, if you look at both of my calves, my right calf is a lot smaller than my left. And that's because it literally had to work for the other limb. As a result of the disuse and it was immobile, it got smaller. That's atrophy. That would be considered pathological because it was as a result of injury. And it also has a very good diagrammatic representation of what happens to the muscle cells. Well, these look like they're the cuboidal cells, so those would be epithelial cells. How the cells atrophy as a result of, this is probably pathological. I believe so. Yes, so that's it. Let's go on. And the opposite of atrophy, something getting smaller, is hypertrophy. It gets larger. Now, hypertrophy is the increase in size, but not the increase in number of the cells. That would be considered hyperplasia. Hyperplasia is the increase in size and number of the cells. So as you're reading this information, at the top of page 38 and 39, it shows a very good diagrammatic representation of hypertrophy as well as hyperplasia. Please make sure you take note of that basement membrane. Go back, find your anatomy notes, and review the different layers. There was a superior layer and an inferior layer, and they both had different names, so make sure you find that information so that you would be prepared in the event that there's a question asked about it. Okay, in the PowerPoint presentation, pathological hypertrophy shows you hypertrophy of the left ventricle. And remember, we talked about the fact that that's the hardest working chamber of the heart because it's responsible for systemic circulation. So upon contraction, it forces all of that oxygenated blood up through the aorta so that the aorta can be that superhighway, so to speak, of all the oxygenated blood to all of the other parts of the body. And then finally, with hypertrophy, we have compensatory hypertrophy. A perfect example is persons that have problems with their kidneys. You've got 2 kidneys, so when one begins to fail, the other one will compensate or try to take up the slack for the one that has the inability to perform the function. Regeneration is the next slide that you have, and it's basically referring to the fact that cells can regenerate, but they only regenerate from the same types of cells. For example, we talked about in anatomy, once again, that muscle cells cannot be replaced with epithelial cells. They can only be replaced by the cells that are within that category of tissue. We'll never have nervous cells replace connective chondrocyte. Neurons can't do that. Cells can only be replaced with the cells that they come from. Because remember, if you go back to the cell theory, cells can only come from pre-existing cells. Cells are the basic units of structure and function, and all living things are made of cells. So in regeneration, physiological can occur, and pathological can occur. I think we've identified the differences between the two. So that concludes that first PowerPoint presentation, as well as Chapter 3. Make sure that you go through, read the chapter, and look at it along with the PowerPoint presentation presented. In Chapter 4, we're identifying different structural abnormalities. So as I pull up that PowerPoint, sorry, got a visitor again. Can you please leave? Okay, golly, I did not realize this was going to be this cumbersome. Okay, structural abnormalities, birth defects, and circulatory disorders. So, first things first. This section is filled with some vocabulary that you'll need to know. It talks about spina bifida and some other causes, but one of the first things that we're going to talk about is the fact that a malformation is a structural abnormality. It can also be called an anomaly, and it occurs by several different things. It doesn't just have to be a birth defect, but there are other things that can lead to structural abnormalities, including chromosomes, genetic mutations, different chemical agents such as alcohol, prescribed medications, drugs, trauma, bacteria. Now, even though on the PowerPoint presentation it lists living agents and viruses are listed under living agents, we know that viruses are not living because they require a host in order to reproduce. Or excessive radiation can also be the cause of various malformations. In the next slide, it goes over the types of malformations, and all the words that are underlined in the PowerPoint presentation you need to make sure that you know. It's not really, I don't think I really need to go over them because they're listed right there in the text on page 45 under limb deformities. Amelia, go back to your medical terminology and let those prefixes and suffixes kind of tell you what they mean. So we have amelia, which is a form of aplasia. Aplasia means that the cells are not present. So since the cells are not present, it can lead to the absence of an extremity. Okay? Aplasia, A means not. No cells present can lead to no limb development. While hypoplasia, we know hypo means below or under. Hypoplasia will be the underdevelopment of a limb. Continuing on, we have hypoplasia, focomelia. All of the terms are right there. I would suggest making some type of index card or note card just so that you will know the differences between all of them. At the beginning of the chapter, it talks about spina bifida. Spina bifida is a condition that occurs typically in infants, in newborns. And it's the incomplete fusion of the most distal portion of the spinal cord. And actually the spine will actually protrude through the spinal cavity. I do have a slide of that in the presentation, so make sure that you take a look at it. It is something that can be treated and taken care of. And it is something that can be prevented. Pregnant women are always encouraged to take folic acid in order to help with the prevention of spina bifida. Hernia. Let me say one thing about a hernia. A hernia is not something that can be removed. I have had persons talk and say things in regard to having to have their hernia removed. Hernias cannot be removed. They can be repaired because a hernia is the protrusion of an organ into another part. For example, we know that separating our thoracic cavity from our abdominal pelvic cavity is the diaphragm, but there's also that esophageal hiatus because our esophagus has to go through there as well. Well, in cases where you strain too much or you use too much of your back in order to lift things, those organs that are at the superior portion of the abdominal pelvic cavity can literally get pushed up into that region. And if a portion of any of the organs, particularly the stomach, you might have a portion of the liver, but typically the liver won't do that, or maybe a portion of the large intestine. If they actually begin to protrude through that esophageal hiatus, then that is a hernia. And so that area has been expanded to allow for a part of an organ to go through. So the hernia would need to be repaired so that it's not as large. Okay, in addition to that, cleft lip and cleft palate, that's the incomplete fusion of the palate, which is the roof of the mouth. Remember, we have the anterior portion, which is the hard palate. We have the posterior portion, which is the soft palate. And also in this section, it talks about, let me go back one.